As a reminder, if you would be sure that you've turned off your cell phones and other paging devices, we'd appreciate it. And folks are still in line outside, so there'll still be a little bit of commotion as we get started. For those of you who haven't already met him at the check-in table, I want to introduce the newest member of the City Club staff, Tim DeRoche, who's joining us as office manager and executive assistant. And Tim's too busy to hear this, but welcome aboard, Tim. Our forum next Friday, October 21st, features political theorist Benjamin J. Barber, author of the book Jihad versus McWorld. Barber has written extensively on the issues of extending democracy in the midst of cultural conflicts in the modern world. The following Friday, October 28th, will feature Governor Ted Kulingoski, featuring investment in Oregon education. This is advance notice to City Club members that club members only may make advance reservations until next Friday, October 21st. Reservations will then open on October 21st. And we think that in order to keep the check-in line moving as swiftly as possible, which would have been good planning today, all lunch reservations that are paid in advance will have tickets mailed to them if the order is received before October 21st. Other events on the City Club calendar include our City Club Citizens Read book discussion, reading Freakonomics by Stephen D. Levitt and Stephen J. Dubner. And we'll be meeting to discuss that book at 7 o'clock Monday, October 21st at the City Club Commons. Please join us, but because space is limited, we'd appreciate it if you'd RSVP to the club. The City Club's Public Life in the Spotlight Theater Series continues in November with a special performance of Russell Lee's Nixon's Nixon, a satire set inside the White House in the dramatic hours just before Richard Nixon's resignation. Join the City Club on Sunday, November 13th at 2 o'clock p.m. at the Coho Theater on 2257 Northwest Raleigh Street. As always, details on these items can be found in your weekly bulletin or online at www.pdxcityclub.org. Our sponsors this quarter are McEwen Gisvold, LLP, and Medico Support Systems of the Northwest, Incorporated. Would you join me in thanking our sponsors? Our program today is co-sponsored by the Foundation for Medical Excellence, and we appreciate the opportunity to partner with them on this program. Our speaker, of course, is former Governor John Kitzhaber, who was elected governor of Oregon in 1994 and re-elected in 1998. And prior to public office, Governor Kitzhaber practiced emergency medicine in Roseburg for 13 years. He was elected to the Oregon House in 1978, and then in 1980 was elected to the first of 3 terms in the Senate. And then in 1985, he was elected as Senate President and served in that position until 1993. In that position, Governor Kitzhaber, then Senate President Kitzhaber, authorized the Oregon Health Plan, which was designed to extend health care coverage to more Oregonians. The plan took effect in February 1994 and was centered on the principle that eligibility for health care coverage could be expanded to more people if cost containment mechanisms such as managed care and benefit limitations were built into the system. Following his terms in office, Governor Kitzhaber began serving as the president of the Estes Park Institute, which conducts 6 annual education conferences for community hospitals. He also serves as the director for the Center for Evidence-Based Policy at Oregon Health and Science University in Portland. He holds an endowed chair on healthcare policy with the Foundation for Medical Excellence. And last year, Dr. Kitzhaber began serving as the president of the Kitzhaber Center, a natural resource center housed at the Lewis and Clark Law School. Governor Kitzhaber.
Thank you. Thank you very much. Actually, I am told that the size of the crowd has something to do with the cheetahs that were outside there. So. Just over a month ago, as Hurricane Katrina was pounding the Gulf Coast, the levees of the Mississippi River broke, sending massive floodwaters into New Orleans, killing almost 1,000 people and dislocating many thousands more. Now, everyone knew that New Orleans was below sea level, that it was surrounded by a dike system that needed work. And everyone knew that it was only a matter of time until exactly this kind of catastrophe would take place. Indeed, in 2001, FEMA listed the potential of exactly this scenario as one of the 3 most likely domestic catastrophes facing our country. Yet here we are pointing fingers, seeking to affix blame, and spending billions and billions of dollars in the aftermath of this tragedy. Now, I share this with you not to find fault with the way the disaster was managed, but rather to highlight the troubling proclivity of this society to ignore obvious problems until they reach crisis proportions, when the only response is to come in on the back end and spend billions of dollars to avert a crisis that might well have been averted. And I share this with you because our nation, by continuing to ignore the growing crisis in our healthcare system, is courting a disaster of staggering magnitude. A crisis and a catastrophe that is imminently avoidable, but only if we act now and if we act boldly. Rising medical costs eat into corporate margins, they reduce the capacity of firms to grow, and they impede our competitiveness in a global economy. They slow the rate of job growth, they suppress wages for existing workers, leading to labor disputes and lost productivity. Today, health insurance for the average family in this country costs $10,800 a year, up from $9,950 last year, and for the first time, exceeding the gross annual income of a full-time minimum wage worker. The rising cost of health care is also having a huge impact on state budgets. In 2003, for the first time, the cost of Medicaid exceeded the cost of primary and secondary education as the single largest expenditure in most state budgets. And as this trend accelerates, it will literally squeeze out the ability of our states to invest in education and in other social priorities, many of which have an impact on the health of our citizens. So my point is simply this: we cannot stabilize school funding without dealing with health care. We can't increase productivity without dealing with this issue. We can't remain competitive without dealing with health care. And we certainly can't claim to be concerned about our children's future without dealing with the healthcare system. And the reason is that the cost of healthcare is rapidly becoming the single largest driver in our exploding national debt that has huge implications for the stability of U.S. currency, and a debt that our children and their grandchildren are going to have to retire. The sheer magnitude of this challenge is staggering. While the administration and Congress are concerned with the stability of the Social Security system, the real problem is Medicare. The Social Security gap is around $5 trillion. Huge, but manageable. It's a structural problem that can be dealt with. By comparison with the retirement of my generation, the unfunded liability in Medicare is in excess of $64 trillion. $64 trillion. Yet seriously addressing this problem doesn't even appear to be on the congressional radar screen. We are asleep at the wheel here. We seem to have succumbed to a sense of powerlessness and resignation, as though this system is so huge and complicated that taking it on is daunting, if not futile. And that is exactly the attitude we have to change, because we are running out of time here. And I don't believe that incremental change is going to get us where we need to be in time to avert the catastrophe that's bearing down on us. What we need in this state and in this country is a revolution. Not of violence, but of vision. Not of arms, but of ideas. A revolution through which we can replace our resignation with hope and our disengagement with a new community-based activism that's driven not by partisan politics, but by an unwillingness to continue to accept a system that's become obsessed with the delivery of health care as an economic commodity at the expense of the health of our citizens. This is a huge and pending crisis of great proportions, and it demands the immediate and serious and bipartisan action by the United States Congress. But I don't think that is going to happen without pressure from the outside, and that's where we come in. This state has provided leadership on this issue in the past, and I think it's time for us to step up and do so again. Thank you. Towards that end, I've got three objectives for my remarks this afternoon. The first is to strip our healthcare system down to its bare bones so you can see and understand its many contradictions and inequities. Second, to offer a straightforward vision of what our healthcare system could look like, what it should look like. And third, to describe a direct action plan to spark the kind of debate in our nation's capital that we so desperately need. Let me begin with a story. A couple of years ago, I took a friend of mine down the Rogue River, an individual who'd been raised in New York, had never been in this kind of wilderness experience before. I guess there's other experiences of a wilderness nature that you get in New York City. This was in August, and the fish were running, the salmon were running. There were a lot of dead fish on the banks. There were some fish in the river, and we drifted by this magnificent male Chinook, maybe 35 pounds. It's just a spectacular creature. Still pointed upstream, but struggling against the current and against his growing weakness. And he was just all scarred up. His fins were torn. He had rips in his sides. He had fungus on his back, and his big jaw was opening and closing and just moving upstream. And my friend turns to me and says, "My God, what is wrong with that fish?" And without even thinking, I said, "Well, there's nothing wrong with him. He's just dying." Now, our society views death as something foreign, something abnormal. We act as though it's optional. I remember a story that former Colorado Governor Dick Lamb likes to tell. He claims to have done this study on death rates all over the world, in India, Uganda, the US, Canada, Italy, France. He found an amazing thing. They're all the same, one per person. But not us, not in this society. We have produced this impressive and almost unlimited array of diagnostic and therapeutic interventions with which we seek to combat disease and disability and somehow stave off the inevitable consequences of aging. And this, in turn, has led to a huge industry that's dedicated not just to the development of these new technologies, but to the financing and delivery of those technologies for the benefit of individuals. And if you view these from an individual standpoint, they are miracles. They're miraculous. But if you view them from a societal standpoint, there's a darker side. Because this system wouldn't create a problem if everyone could afford the cost of his or her own health care. But that's clearly not the case today. Today, we increasingly rely on public resources to finance the cost of care for individuals. We've created a system that focuses unlimited care or benefit one individual at a time, while increasingly relying on limited public resources to finance the cost of that care. So what's really in contention in the healthcare debate is how we allocate our public resources and who benefits from that allocation. What people want to do with their private after-tax dollars is their own business. What we do with public dollars should be everybody's business. And let me give you an analogy. One of the consequences of my dual experiences as a physician on the one hand and a public policymaker on the other has been an acute awareness of the fact that how I allocate resources as a doctor is very much different than how I allocated resources as a legislator or a governor. As a doctor, my commitment is to the individual right in front of me, to do whatever I deem necessary regardless of cost. As a legislator or governor, I can't ignore cost. And my commitment is to get the greatest health benefit possible for as many people as possible with the limited resources that I have available. So with public resources, we're dealing with resources held in common, and they need to be used to benefit the larger society from which those resources flow. In other words, the goal is to maximize the benefit across the population. So the vision for our revolution needs to reflect that premise, that objective. And I think the vision is astonishingly simple. It's the adoption of an explicit policy of universal coverage for a defined set of effective health services. And indeed, there is a model right in front of us that bears our scrutiny, and it's the way we finance and deliver public education. Now, I'm not saying there aren't problems with a public school system. There are, but I want you to step back for a moment and just consider the eligibility and financing mechanism that's involved, okay? In the United States, we have a policy which entitles all children to publicly subsidized education based on the widespread recognition of the importance of education, not just to individuals, but to our larger society. And to implement that policy, we publicly subsidize our schools with general tax revenues. So everyone who pays taxes contributes to the public school system. Rich people, poor people, people with kids in school, and even people who don't have kids in school. And all children, regardless of their economic circumstances, are eligible for publicly subsidized education, and they all get the same benefit, which in this case is the educational experience of 12 years in the public school system. So we have universal coverage for a basic level of care or benefit, in this case, an education. Nobody's left out, and the public pays for the same benefit for everyone. Now, parents who want to give their kids additional educational opportunities, or a richer benefit, if you will, a tutor or enrollment in a private school, they're free to do that. But we don't subsidize those additional benefits with limited public dollars. And of course, that is not an option that's available to everybody. It's a function of disposable income. People who don't have a lot of disposable income have to rely on the public school system to educate their children, which is why it's so important, why it's a cornerstone of a democratic, pluralistic society, why we care about what happens to the Portland public school system. Now, when we run out of money in the school budget, what do we debate? We debate the benefit level, or what is covered. I mean, we complain about how much it costs to educate a child, and we talk about waste and the need to increase efficiency, but at the end of the day, inadequate revenue is reflected in what is covered, in bigger class sizes, in a shorter school year, in fewer electives. And that reduction in benefit applies to everyone who's enrolled in the public school system. What we don't debate is eligibility. I've never heard anyone in Salem say, we don't have enough money this year, so we're going to not teach the 11th and 12th grade. Or for this biennium, if you're over 16, you can't go to school anymore. If your family makes $40,000, sorry, we're out of money, you stay out for a couple years. We never question our commitment to universal coverage, do we? Everyone stays covered for the same basic benefit, even if that benefit has been reduced because of fiscal necessity. Now, that's a far cry from the eligibility and financing structure in our healthcare system, which was developed not around a commitment to universal coverage, but rather around this concept called categorical eligibility. In other words, unlike our school system, to qualify for publicly subsidized health care, you have to fit into a category. And those categories were created in the mid-1960s with the passage of Medicare and Medicaid. Now remember that 40 years ago, when these programs were adopted, when Medicare was adopted, poverty among the elderly was twice that of the general population. So Medicare was a noble effort to try to improve financial access to health care for older citizens. It's an entitlement program that begins at retirement, regardless of the financial means of the retiree, and it's financed largely by taxes paid by people who are working. It covers acute care, but interestingly enough, it doesn't cover long-term care. The point is, that made a lot of sense 40 years ago, but the clinical and demographic environment in which health care is delivered has changed dramatically in 4 decades. This program has remained essentially the same. Whereas in 1965, the elderly, people over the age of 65, represented the single poorest segment of American society. Today, people over the age of 65 represent the single wealthiest segment of American society, followed only by people between 55 and 65. But because the program's not means-tested, you have this situation where all people over the age of 65 are entitled to publicly subsidized health care, paid for in part by tens of millions of working families who can't afford health care for themselves or for their children. Now, Medicaid was also enacted 40 years ago, and it was designed to improve financial access, again, for certain categories of poor people. Not all poor people, certain categories. And those categories were created by Congress and include kids in poor families that are on welfare, the elderly who need long-term care because that's not covered by Medicare, certain categories of pregnant women, and people who have disabilities or who are blind. Now, unlike Medicare, Medicaid is not an entitlement program because eligibility is not just based on financial need. You have to fit into a category. So as a consequence, there are millions of poor citizens who are not eligible for Medicaid even though they're deeply impoverished. So what we did again 40 years ago is we made a distinction between the deserving poor who fit into a category and the undeserving poor who don't. Now, the enactment of these two programs gave us our modern health care financing and eligibility structure with two major third-party payers, the government, Medicare and Medicaid, and the private sector, largely through employment-based policies. But because this system was developed around categorical eligibility rather than universal access, this large gap began to develop between the public and private arms. And in that gap, if you think about it, are people who don't fit into a category. They're not 65, so they're not eligible for Medicare. They don't meet the income or categorical requirements for Medicaid. They don't have workplace-based coverage, and they just can't afford the cost of a private policy in the individual market. Now, in that coverage gap, we have over 45 million Americans. 600,000 Oregonians are in that coverage gap. And that doesn't include tens of millions of people who are underinsured and literally one illness away from personal bankruptcy. In fact, the inability to pay a medical bill is the second leading cause of individual bankruptcy in this country, second only to job loss. So this gap exists, again, because we've organized the system around categorical eligibility, not around universal coverage. And so we have avoided answering the most basic question that every other industrialized nation on the planet has answered. And it's a very straightforward question. Who has the responsibility to finance the health care needs of people who can't afford to do so themselves? And because we've never answered that as a matter of policy, we've allowed the economic market, by default, to answer the question for us. But economic markets are designed to make a profit, not to foster social responsibility. So it should come as no surprise that nobody goes out and competes for people who can't pay them. Why are we astonished by that? And in fact, in our market-oriented terminology, people with a payment source are called what? Market share, right? And we compete for those. People who can't pay are called liabilities, and we try to avoid them through adverse selection and cost shifting. Now, cost shifting is very important to the American system, and it's important to understand it. It serves as a pressure valve, but it also reduces the pressure and therefore the political accountability needed for real change. And here's how it works. The people who are in that coverage gap, when they get sick enough, they go to your community hospital emergency department, where federal laws like EMTALA require that they be seen and treated, and the uncompensated costs are simply shifted back to the two third-party payers by incrementally increasing their insurance premiums or their bills. That's where part of your region's premium hike comes from. It's subsidizing this cost shift. Now, the third-party payers also then try to shift the cost back on individuals. States manipulate the income eligibility standards to reduce the number of people who are covered by the Medicaid program. 60,000 Oregonians have been dropped off the Oregon health plan, essentially by manipulating eligibility over the last 2 years. And the employers do exactly the same thing. They either drop coverage altogether, which is happening at a rate of about 4.5% a year, erosion in private sector employment-based coverage, or they increase co-payments and deductibles that shift out-of-pocket expenses to employees who at some point can no longer afford the cost of care, and these actions simply drive more people into the coverage gap. They go back to the emergency room, repeating the cycle. Now, that cycle only works if we're willing to let people die on the ambulance ramp if they can't pay for their health care. It's the only way this system works, but we don't do that. It defies logic, it defies common sense, and it costs us a whole lot more to treat people in the emergency room on the back end than it would if we provided people access to some level of care on the front end. And let me give you an example that I shared with you a few years ago just after I left office, but it's a poignant example, and it makes the point, I think, very powerfully. In February of 2003, the Oregon legislature, in order to help balance the Medicaid budget because of the recession, discontinued prescription drug coverage for the medically needy program and for people who were on the OHP basic standard benefit package. Now, as a result of this decision, a gentleman in his mid-30s named Douglas Schmidt, who had a seizure disorder, was no longer able to access the medications that controlled his disease process. He was still eligible for Medicaid, but the program no longer paid for the pharmaceuticals. So after about 10 days, he experienced a sustained grand mal seizure. He ended up with severe brain damage on a ventilator in Good Samaritan Hospital, where he stayed for a number of months, was eventually transferred to a long-term care facility, where he died in November of 2003 once the court had ordered a discontinuation of life support. Happened right here in our town. The cost of his medication was around $14 a day. Cost of the ICU exceeded $7,500 a day, a total bill of $1.1 million, all of which was billed right back onto the state Medicaid program. So we didn't save any money whatsoever as a society because of this implicit rationing decision. We increased our fiscal liability, and as a consequence, dropped more people from coverage, perpetuating this kind of human tragedy and fiscal disaster. My point is simply this: we're going to pay these costs one way or another, implicitly or explicitly. And by refusing to do so explicitly, guided by some thoughtful policy, the cost is much, much higher, both in economic terms and in human terms. Think about it. Douglas Schmidt died of budgetary and political expediency, in effect, based on a policy that said, we won't pay a few dollars a day to manage your seizure disorder, but we're happy to fork out over $1 million of taxpayer funds to sustain you on life support after your seizures have caused irreparable brain damage. That's the policy. It's a policy that says we won't pay pennies to manage your blood pressure in the community, but we'll pay the cost of your stroke in the ICU unit once you've had it. That we won't make sure that all the women in Multnomah County have good prenatal care, but we'll be happy to pick up the cost as a society of resuscitating your 500-gram infant in a neonatal intensive care unit, and that simply shouldn't be acceptable to any of us. Now, this isn't going to change unless we refuse to continue to allow our thinking and our reform efforts to be constrained by a 40-year-old financing and eligibility structure that reflects the realities of the last century. How long would Microsoft last if Bill Gates held on to a 10-year-old operating system, or a 5-year-old operating system, or one that's 18 months old? We cling tenaciously, without question, to a 40-year-old healthcare operating system and wonder why we can't meet the healthcare challenges of the 21st century. We need to stop defending programs and start solving problems. And the place to start is through by approaching our healthcare system with the same eye to equity and sustainability with which we approach our public school system. And if we did, we would have as our objective a healthy citizenry, which doesn't just mean healthcare. It means some healthcare, but it also means housing, a job, an education, and a clean environment. And we would then adopt an explicit policy of universal coverage for a defined set of effective health services paid for by public resources. So all citizens, regardless of their income, would contribute to the subsidy, and all citizens, regardless of their income, would receive the same basic benefit. And citizens who wanted to access services not covered by the public sector, which will necessarily be limited because of the constraints on our budget, could get them. But we wouldn't subsidize those additional services with limited public resources. Now, I want to make it clear that I'm not suggesting we simply move to a Canadian-style single-payer system here. There's a lot of ways to do this, but the bottom line should be this. We need to demand a different standard for that part of the healthcare system that's paid for with public resources than for that part of the system that's financed with private after-tax dollars. And what we should demand is what we demand for the allocation of all other public services. First, that we actually get a health benefit for the dollars we're spending on health care. And second, since these are public resources, that the allocation benefits everyone, not just some of us. That it doesn't leave 600,000 tax-paying Oregonians out or 45 million Americans. Now, using this kind of public education model as the financing and delivery structure for our healthcare system in no way predisposes the role of market forces in the healthcare system. It doesn't presuppose the role of employers or even of the private commercial insurance industry. All it does is ensure that we have equity and universality and effectiveness in the public dollars that we spend on health care as opposed to other priorities. Now, the case for this kind of model can be strengthened if we compare it to the financing eligibility structure in our current healthcare system. Okay? In our current healthcare system, we have no explicit policy to guide the allocation of our healthcare dollars. We have no explicit policy of universal coverage and no explicit set of subsidies to finance care for people who can't pay for it themselves. We respond to fiscal pressure by manipulating eligibility rather than looking at benefits, and we use our resources to subsidize health care for very well-to-do citizens at the expense of many citizens who have little or nothing. Now, I submit to you that if we were to take the policies in our current system and make them explicit, nobody in this room could support them, and no one in the United States would vote for them. And to prove the point, we're going to take a minute here and draft a bill for an act. And the question, the assignment here, is if we wanted to create the U.S. healthcare system as it exists in October of 2005, what would the bill look like that Congress would have to vote on? And we're going to give this bill a bold and stirring name. We're going to call it the Healthcare Equity and Empowerment Act of 2005. Because, as all of you recognize, in the United States Congress, the title of a bill is not required to reflect its content. Okay, our bill has 4 sections and a preamble. Preamble, sub 1. There shall be no explicit policy objective adopted to guide the allocation of public health care resources. Sub 2, no clear responsibility shall be assigned for financing the health care needs of citizens who cannot afford to do so themselves. Section 1, categories will be established to differentiate between the deserving poor and the undeserving poor. Sub 1, the deserving poor shall include women who are pregnant, families with dependent children, and those who are blind or have disabilities. These citizens shall be entitled to publicly financed health care. Sub 2, the undeserving poor shall include poor women without children who aren't pregnant and all poor men. These individuals shall be denied publicly subsidized health care, no matter how deeply impoverished they may be. Section 2, sub 1, all those over the age of 65, regardless of their income, shall be entitled to publicly subsidized health care. Sub 2, all employed citizens under the age of 65, regardless of whether they can afford health care for themselves or their families, will be required to donate a portion of their taxes each month to subsidize the health care needs of wealthy citizens over the age of 65. Section 3, sub 1. The program for the elderly, Medicare, shall be prohibited from covering long-term care services in spite of the obvious aging of the population. Sub 2, the public program for the poor, or some of the poor, Medicaid, shall be required to cover long-term care services. Sub 3, the elderly who need long-term care services will be required to spend themselves into poverty in order to become eligible for Medicaid, at which point their needs will compete directly with those of poor women and children, in some cases their own children and grandchildren. Section 4, the criteria of financial need and ability to pay shall not be considered in determining who should be eligible for public subsidy. Sub 2, the relative effectiveness of medical interventions in actually producing health will not be considered when deciding what to purchase with our limited public health care resource. I could go on. But I think I've made my point. Nobody could embrace the policies of the Healthcare Equity and Empowerment Act of 2005, but that is the operating system that guides the U.S. healthcare system and the one we have here in Oregon, and those are exactly the policies that have to be exposed and challenged and changed if we hope to realize a more equitable and sustainable healthcare system in this state and in this country. So the question is, how do we go about making it happen? Well, there's no question, but realizing this vision is going to require definitive action by the United States Congress. But making Congress take that action, I think, is going to require the introduction of a random factor from the outside that will put pressure on Congress to take that kind of action. And doing that requires 3 steps. The first step is we've got to be able to articulate a vision of what we think the healthcare system ought to look like. The second step is we've got to expose the contradictions and inequities in the current system. And third, we've got to create a tension between our vision and the status quo. Now, the enactment of the Oregon Health Plan a decade ago is a real-life example of the power of this kind of approach that starts at the state and goes back east. Between 1989 and 1993, this little state that at the time had less than 3 million people became the focal point of the national health policy debate, and the reason was we passed a bill that was illegal. We basically said we're not going to be constrained by the existing structure of Medicaid because it makes no sense. And so we redesigned the system the way we thought it ought to look to create a more equitable, more rational way to provide health care to low-income citizens, even though we knew we couldn't implement it without getting waivers from the United States Congress. But the process of seeking those waivers forced federal policymakers to compare the status quo with a more rational way of allocating these same resources. It maximized the pressure for change, it exposed the inequities in the current system, and the result was the Oregon Health Plan, which, although it's fallen on hard times, has helped well over 1 million citizens in this state over the last decade get timely access to the healthcare system. I believe that creating this kind of tension is the only way we can jumpstart this debate in time to get ahead of the deficit and all the other things that are pressing down upon us. This is the random factor, but it has to be undertaken on a much broader scale. So what I'm suggesting is that by starting here in Oregon with a crisp, clear vision of what the U.S. healthcare system should look like, and then by seeking to realize that vision, either through the legislature or a direct vote of the citizens, we can, through seeking waivers, challenge the fundamental structure of the entire U.S. healthcare system and not just the Medicaid program. And that is the challenge I want to leave you with today, to embark upon just that kind of project. Now, from the stunned looks out there, I can tell you that I can recognize that some of you may think that what I'm proposing here is unprecedented and bold, but it is something that is well within our power to do. It requires not only courage, but obviously it requires taking some risk as well. But William Jennings Bryan once wrote that destiny is not a matter of chance, it's a matter of choice. It's not a thing to be waited for, it's a thing to be achieved. And that is exactly the question before us as citizens of this state and of this country. Whether we want to try to engage in shaping our future, or whether we want to just sit back passively and let it happen to us. The question before us is whether we still have the will and the capacity in this state to come together as a community. Because if those of us here in Oregon are unable or unwilling to make the effort to agree on what the healthcare system should look like, at least that portion of it that's financed with public dollars, I don't know why we think it's going to happen for us by somebody inside the Beltway. And we will, by default, be shackling ourselves to the failed policies of the past and allow our future in this state to become a matter of chance rather than a matter of choice. And frankly, I think we are a whole lot better than that. Albert Einstein once said, "We can't solve today's problems by using the level of thinking we were at when we created them." That's true. But I also think that the late Western novelist Edward Abbey put it more succinctly, if perhaps not quite as eloquently, when he said, "Society is like a stew. If you don't stir it up, you get a lot of scum on the top." Our job, it seems to me, is to stir it up. Our job is to recognize the fact that the responsibility to bring about the reform that we all recognize needs to happen doesn't belong to someone else. It belongs to us. It belongs to you and me and citizens and communities throughout this state and throughout this country. It's something we can do, and it is something we must do. And if we're not willing to do it for ourselves, then we need to do it for our kids. A gift for the future. For those who are going to inherit this healthcare system that we created and which by default we are perpetuating. Let me close this noon with the words of Oregon poet Kim Stafford, who runs the Northwest Writing Clinic at Lewis and Clark and is one of my personal heroes. And Kim, I think, very eloquently defines the challenge and the opportunity and indeed the responsibility that lies before us in what he calls Lloyd's story. Lloyd Reynolds, the international citizen of Portland, spent his last days in pain, silent, unable to speak or write, lying in a hospital bed. On his last day at home, as his wife scurried to pack his suitcase for the hospital, Lloyd made his way outside to the garden, and there she found him on his knees, awkwardly planting flower bulbs with a spoon. "Lloyd," she said, "you'll never see those flowers bloom." He smiled at her. "They're not for me," he said. "They're for you. Salmon coming home, they're for you. The call of the wild geese, they're for you. The last old trees, they're for you and your children to the 7th generation and beyond. They're all blooming into being for you." That's our challenge, to plant the seeds of tomorrow, to change the world by acting and by leading and by re-engaging in this debate, not as victims of the status quo, but as proud architects of a new future. Thank you very much.
It's time for questions from the floor. Questions are a privilege for City Club members only. There are 2 microphones up here at the front. And you're welcome to join the City Club, by the way, in order to ask a question. First question will come from our board host, Bill KRAMER. Bill is our club treasurer. He's a consultant in healthcare management, finance, and policy, and he also serves on the boards of Friendly House in Northwest Portland and the International Sustainable Development Foundation. Bill?
Thanks, Doug. And thank you, Governor Kitzhaber, for that eloquent and impassioned speech and call to action. Earlier this week, I asked a lot of people what question I ought to ask Governor Kitzhaber at City Club Lunch Forum. And the most popular question was phrased in a variety of ways, but it kind of boiled down to, are you or aren't you? We won't put you on the spot today.
I doubt that very much.
A healthcare question, though. In your speech, you described very clearly the irrational and inequitable financing system for healthcare. Many critics have pointed out, though, that in addition, the healthcare delivery system needs significant improvements. We have tens of thousands of people who are dying every year in hospitals, avoidable deaths. We have millions of people, whether they have insurance coverage or not, getting the right care at the right time. We have inefficiencies. We have waste in the system driving up rising costs. In addition to the improvements you've talked about in the financing of healthcare, what can be done to improve the delivery of healthcare for all of us?
Well, if you assume that your reform effort is going to cover everybody, and that you're going to deal just with the public resources in the system, you've really dealt with two of the four elements of the healthcare system: eligibility, financing, benefit, and delivery. So we can focus our creativity by using the public education model as the financing eligibility structure. We can focus our creativity on exactly the benefit, that is, what is it we're going to give to people and make sure that it's actually beneficial in terms of health, and on the delivery system. Because if you think about it, the uninsured is not the problem. It's a symptom of the problem. The problem is in the archaic structure of our financing eligibility system and in the incentives and payment models within the delivery system. The people in the delivery system do exactly what their incentives tell them to do. They're not bad people. They're playing the game as we decided. We need to redesign the game, and this is an opportunity for us to sit down in this state and have a conversation that I don't think is any longer possible inside the Beltway.
John Polnick, City Club member, and my company is also a proud sponsor of the Friday Forums. I encourage all entrepreneurs out there to take up that challenge. Governor, we elect a new president in 2008. You receive a phone call. I'm not running. You receive a phone call.
It doesn't work for me.
And the president asks you to join his or her cabinet to become Secretary of Human Health Services. What is your response and why?
I would say no. It is an incredibly, and Mike Levitt is a good personal friend of mine, former governor of Utah, who runs HHS now. It is an impossible bureaucracy that is designed to administer a structure that was created in the middle of the 20th century with all sorts of rules and regulations that have been accreted onto it over time without any sense of common purpose or common policy. It's like moving the deck chairs on the Titanic. I do not think this system can be reformed. I think the system has to be transformed and fundamentally changed by going back and asking ourselves, what is it we want this system to deliver? It's not health care. We don't care about health care. We want to be healthy. The objective is health, not health care. And so we need to redesign the system. I don't think you can do that from inside HHS. The president could do it by essentially calling these questions and using that bully pulpit to talk about the fundamentally broken system and how it's going to bankrupt our country without making us healthier as a society, but not from inside of HHS.
Governor Dr. John Kitzhaber, my name is Gavin White, and I'm the chair of the Multnomah County Democrats. I'm also a member of this organization, which does not endorse or support any candidate or party. I'm proud that you, a Democrat, are advocating so clearly and strongly for the well-being of working families and of all Oregonians. Obviously, if this is to be a successful campaign, you could use some allies, and all of us are potential allies. All Oregonians around the state are potential allies because we're all invested in this struggle. You could probably also use some help from publicly elected officials. Without naming names, could you identify which public offices are best suited to advocate for this transformation, as you describe it, and which to oppose it?
Well, I think that any statewide elected office offers a tremendous pulpit for this message. If I was Susan Castillo, for example, in the Department of Education, there's nothing more threatened than public education by the growing cost of health care and by putting our current and by continuing to fund our current programs by adding it onto our kids' credit card. That is threatening the fundamental structure of public education in this state. So any statewide office could do it. Certainly any elected leadership position, a speaker, a president of the Senate, majority leader. But I can tell you, it doesn't take an elected official. What we got to be asking ourselves is what, as individual citizens, are we willing to do? What commitment are we willing to make to reframe this debate and push this debate forward? Because it is your children and grandchildren who are going to pick up the tab for this system if we don't fix it.
Linda Kaiser, City Club. You spoke very eloquently about costs connected with eligibility, costs connected with the benefit package. Would you say a few words about administrative costs and how you might control that 25 to 30%, depending on who's counting, administrative costs and overhead?
Well, I think the question had to do with administrative costs, and again, the answer to that depends on how you want to reorganize those resources. I think that one of the problems with administrative costs is that we're not very clear about what we want the outcomes to be. It's not really clear what it is we want our healthcare system to deliver for us. And right now, I think the common paradigm is we want it to deliver healthcare. We don't ask, you know, when you get a car from Detroit, you don't want just a car, you want a car that works, that has quality, that doesn't need a lot of maintenance, that isn't going to fall apart or lose its wheels. We don't ask any of those questions about healthcare. So I think there are enormous administrative costs in the system that can be wrung out. I also think there are enormous costs in inappropriate medical care that's being done and in medical errors and in inappropriately putting people in the hospital. I mean, so I don't think the problem's money here. I mean, Italy spends around $2,000 per person per year on health care and has much better population health statistics than the United States that spends probably $5,800 per person. So it's not money. It's basically creating a venue where people can engage first as citizens and second only as stakeholders and begin to talk about what we want the system to deliver for us. And that's where it's got to start.
Gwen Vermilius, City Club member. I'm going to follow up on Gavin's question and ask you to name names about organizations that this club could get behind or members of this club could get behind if we shared your vision, if individuals in this group, well, we could write letters to all the folks in office we'd like, are there groups that we should be backing in order to make this happen?
I think, first of all, I'll make it really clear, this isn't a partisan issue. This is an issue that affects us as a society and who we are and the legacy we're going to leave. I just want to say that it's very important. We've got a process that's being sponsored by the Foundation for Medical Excellence that's trying to actually have that conversation. I'm going to take just 1 second if I can, and I can do this in 60 seconds. What we've done is we've identified essentially we've made some assumptions about the magnitude of the public dollars we spend in Oregon every year. It's about $6.5 billion. If you include Medicaid, Medicare, and the deductibility of employment-based health insurance premiums. So the question is, if we have $6.5 billion and 3.5 million people, and anything were possible, how would we design a benefit and a delivery system that would maximize the health of all of our citizens? It's frightening to people to actually say, okay, what would it look like? But we think that the key groups here that need to be involved in that discussion are the provider groups who actually deliver in the healthcare system, the hospitals and the other providers, the physicians. We need consumers. We need people from the unions who actually have workplace-based coverage, as well as people who don't, and people who are elderly. We need the business community desperately, because if you provide health insurance to your employees, you are paying a hidden tax that's going up 4 or 5 times the rate of inflation. And we need the insurance industry as well. So the question is, can you have a 3-part discussion that starts out, if anything were possible, what would the best system look like? So not what's good for the Hospital Association, not what's good for the AFL-CIO, but what's good for Oregon. Then the second question, which we never get to in this debate, is, okay, here's the system. If it were implemented tomorrow, what would be the impact on me as a business person, or on an elderly person, or a doctor practicing in Grants Pass? That's where you make the politics and costs explicit. Then the third question, which is the exciting one, is how could we mitigate that and create a win-win situation without diluting the objective of the exercise in the first place? So the answer to your question is all of those groups, I think, need to be involved in this process.
Thank you very much for your excellent comments about the terrible status of our health care right now. But you mentioned the status of Medicare. But would you comment, please, on the new Medicare drug law D? The people that are on Medicare on Medicaid will be all right. The people that are low income above Medicaid are really going to be hit if they have any kind of severe problems, and they're stuck with a donut hole, and how are they going to manage?
Well, I think the Medicare prescription drug bill is the poster child of an utterly dysfunctional federal process. There are many elderly citizens in this country who need and deserve publicly financed health care. There are also many working people and kids who deserve exactly the same thing and are entitled to nothing. And that debate in D.C. was all about partisan advantage, and it didn't, in my view, have anything to do with health care or about the elderly. The three most salient questions that were never put on the table were, why do these drugs cost so much in the first place? No one asked that. The second question is, what is the health benefit we're going to get for $400 billion, which is now, by the way, $800 billion, all of it being paid for on our kids' credit card. And the third question, which is the most salient one, is if we're going to spend more money in health care in this country, where should the next dollar go? What's the policy that would take the one group of citizens who have an entitlement to health care and spend another $800 billion there before trying to extend basic health care services to 45 million people who don't have anything? So I predict that it's going to implode. There will be an opportunity to come back and revisit it. It's not affordable, and it doesn't really get at the issue of health outcomes for dollars spent on pharmaceuticals.
Hi, Leslie Hildula. I've heard your speech about a year ago, and I can say that based upon the tear stains on my napkin, you've gotten even better. Thank you. It seems like we're talking about, in the end, passing some laws, and isn't there linkage between campaign financing reform, as in public-funded campaigns, and our ability to create the kind of laws that we need?
Well, I have always been a proponent of publicly financed campaigns, but I do have just a couple of comments. I don't think that's going to happen. I don't think we're going to get the kind of campaign finance reform that we need, because the very people who are going to be disadvantaged by it control the process that's required to change it. You know, the best opportunity is to get something through, I think, on the ballot, but I don't think you're going to see that coming out of the legislature or particularly out of the United States Congress. But I do want to say one other thing. There's no question that campaign financing reform is important. But it also says something troubling to me. I'm not saying you're saying this, but I mean, the drumbeat says to me that we just aren't smart enough as individuals to make informed decisions, and we're going to believe everything we see on television. If they send us slick flyers every day in the newspaper, we're going to be swayed by that. And you know, that's a choice. We don't have to be. You know, there's a certain amount of sweat equity that goes into being a citizen, and it's not just voting. It's taking the time to really educate yourself and not rely on the Oregonian, not rely on paid television ads. Do it for yourself. We can do that. There are lots of organizations out here where we have those resources. And so while we should push forward to try to to fix the campaign finance laws, we need to shoulder some of that responsibility, I think, ourselves as citizens.
And Kurt Wabering, member. I understand that in the Oregon Health Plan, that there was developed a priority list of medical services based upon what their health benefits are and what their costs are, basically a benefit cost analysis, and that the plan would then fund what it could of the list. Is that the kind of model that you have in mind when you're talking about universal health care?
I think you have to have, particularly if you're dealing with public dollars, I think, you know, people can buy whatever they want with their after-tax dollars, whether it makes any sense or not. That's what you get to do in this society. But I think with the public dollars, you have to have some explicit framework where you can match the dollars you have available with the benefit you're going to buy. Because at the end of the day, the basic benefit is what we are willing to essentially subsidize. And so all the Oregon Health Plan was a budget box and a priority list. It said you can't ration people by changing eligibility. We determine provider reimbursement rates on the front end by giving that list to an actuary. You have to make a resource allocation decision and decide whether it's more important to add more money to the health care budget or put more kids through the Head Start program. And that kind of explicit process, I think, it has taught us a lot. And we've been doing it every 2 years for a decade. The methodology is very good. It's utterly transparent. And you can go through that priority list, for example, and you can tease out those condition treatment pairs that go to chronic care, which is about 60% of the cost in the system now. And you can figure out, you can just start with that piece and figure out different payment models, different care models to reduce that. So we're way ahead of the country in terms of having something, and you can actually log on to the Oregon website and look at the Health Services Commission, look at the priority lists, look at their methodology, and see the work that they've done over the last 12 years. It's really remarkable.
Anne Marie Claire, City Club member. I have two questions today, Governor. One is, in your work in this area, have you been approached by other governors who wish to use the same model in their states? The second question is, have you thought about taking a tip from, you know, the DFA campaign and launching a website that citizens like myself and others in this room would easily go to and look for meetup meetings and places to start the action on this?
The first question, Governor Gregoire has contacted me from Washington. This is having, you know, figured out sort of what a direct action plan might look like. It's fairly new, and I think I'll definitely get some interest from a number of governors, but Christine Gregoire has actually called and wants to sit down and talk about it. We actually have a website designed, and we are essentially trying to find the funding to get it up. It's going to be through the Foundation for Medical Excellence because we do think there's a real opportunity to use the website to organize people, to inform people, and to begin to move in this direction. That hopefully within 2 months we'll have that up.
Carla Kelly, City Club member. Governor, you've spoken very eloquently about our need to reinvent what is a completely dysfunctional system. In your opinion, are there any other countries that have gotten it right? And if so, what did their system look like?
Well, I think that there are lessons I think you can learn from a lot of systems. Australia, for example, is very explicit about the fact that there are multiple tiers, that people who have more disposable income can always buy more health care than people who don't. That's true everywhere. But they've got a parallel insurance system that you can buy into that helps you jump the queue on things like, say, not an emergency stuff, but like, let's say, shortens the queue for a hip or something like that. No other nation, so all other nations that have some form of universal coverage, who have recognized there's got to be a floor, I think are way ahead of us. I don't think anybody, however, has actually been honest about creating a transparent framework where we can actually begin to ask ourselves, what is the relationship between investments in health care and the health of our citizens? And I think it's important not to anger any of my fellow providers here, but there is only a tenuous relationship between modern medicine and population health. I mean, the big gains that we've made in terms of the health of our population and in terms of longevity have to do with public health measures, cleaner air, cleaner drinking water. There's a direct correlation between people's educational level and their health status, which is really a function of funding education, ensuring people have a job and economic opportunity. So I think that we could lead the way in taking the work that's done by people like Don Berwick and John Wenberg. There's a tremendous amount of information out there that you could apply to this kind of process to really begin to tease apart what a health benefit is. And so instead of just arguing about, we're going to cut my benefits, argue about making sure that what's covered actually delivers a health benefit and the larger objectives of our society.
Jody Weiser, City Club member. I think it's great that you're running for health care for our country as your new campaign. But it seems to me that if we don't address two things that are kind of problems in our culture and not in other cultures, we're going to have a hard time controlling our healthcare costs. And one is that we don't seem to be able to face end-of-life decisions well. So we spend probably more than Italy spends on the average citizen in their last 2 months of life. They would spend that amount in the whole lifetime, 140,000 or so. And the other is that there's a lack of maybe a sense of responsibility for our health or something that makes our society much less healthy than most other supposedly developed nations. And how do we address those kind of ethical choices about being responsible for how healthy our bodies are and for how we accept death?
Let me try to take a cut at that real quickly. I know we're winding up here. The second part of the question is I don't believe that health care is a right. I mean, why should you have a right to something that doesn't produce health? And to what extent can you exercise a right that's paid for by somebody else? But what I do believe is that in this country, everyone should have an equal opportunity to be healthy, which means that they should have a right to some basic level of health care, but they also have to assume some degree of individual responsibility about their lifestyle choices and the impact that has on the overall healthcare system. Because what we have here really is like Garrett Hardin's tragedy of the commons. So you have to put into the system some incentives and some transparency that does measure and get at the issue of individual responsibility. But to be healthy also means you need to have a job. You need to be able to dream the dream of upward mobility. You need to be able to have a house. So I think you need to change the context. The first part of the question is I think you can get at that issue through the payment models. And I'll tell you a little story here on the way out. My parents, who are very elderly and are failing, particularly my mother, we went to see a physician a while back, and she decided that she wanted to stay at home. She didn't want a lot of fancy procedures done, and so the doctor said, well, we'll check your blood work in a couple of months, and we'll see how you do. And I said, why? She said, I beg your pardon? I said, why are you going to check the blood work? Because if you check the blood work on an 88-year-old woman, you're going to continue to find abnormalities, and if you decided you don't want to run them all down, why do it? And she's a wonderful internist. She is not paid under this system to spend an hour with an aging patient, talking through the choices, making the system transparent and understandable, but that physician will be well reimbursed for hospitalizing my mother, for doing endless MRIs and transplants and diagnostic and therapeutic procedures. And I would bet you, and they won't pay $18 an hour for someone to let her live in her own home and die in her own home with her family around her. Now, I would bet that if you talk to most senior organizations, most people don't want to die in a hospital. They don't want to die in an ICU. They want to die in a different kind of a setting, where there's care as opposed to health care. So if you can create a framework, and I'm sorry I'm rambling on here, but this is a really important point. If you can create an explicit framework, so you can actually, let's just look at what Medicare pays for and what it doesn't pay for. Is it really addressing the needs of an aging population, or isn't it? That's a conversation we can have, and I believe individual citizens are perfectly willing to make those choices, but you've got to put the caring back in healthcare, and you can do that, I think, by looking at the dollars and reorganizing them in a way that actually delivers those values that I think all of us really aspire to. Thank you very much.
One way to continue this discussion, if you'd like to, is to go onto the club website and log on to our Citizens blog, where we'll be discussing this weekend. Governor, thank you very much, and we're adjourned.